I'd like to invite our first speaker, Dr. Sandeep Mevada. He is MD Radiology and Head and Consultant Radiologist at Satyam Diagnostics. He is having several awards and honors. He is a Treasurer of Gujarat State Chapter of IRIA. He is a Scientific Chairman and Co-Chairman in various conferences. He is having multiple paper and poster publications, and his main area of interest is body imaging and interventional procedures. So today, Dr. Sandeep Mevada will deliver a lecture on pancreatic fat and type 2 diabetes. So over to you, sir. Thank you.
Thank you very much. First of all, I would like to thank Dr. Vipul, Dr. Dhruvi for giving me the mic on the very early in the morning, and just wish him happy Friendship Day. He's my MBBS batchmate and he's very, very close friend of mine. So today my topic is evaluation of pancreatic fat in diabetes. So first, when he told me that you can take a lecture or about radiologist perspective, what evaluation of pancreatic fat. So I thought that this is the clinician conference, all are clinician, all diabetologists. So what I am here, why I am here, what does radiologist do, what I can contribute or what I can do. So now I have digged out what is the evaluation. So we are doing usually CT scan, MRI and all the thing with pancreatic pathology, more on in like or pancreatitis, pancreatic tumor, staging, the ifs and buts, and what the evaluation, how the fat evaluation helps. So I learned that diabetic and metabolic disorder, usually a pathology is of liver or pancreas, or it affects liver or pancreas, or it is associated with liver or pancreatic pathology. Most of the GI physicians or all the physicians are focusing on the liver. We all know that NAFLD, non-alcoholic fatty liver disease, metabolic associated fatty liver disease, hepatic steatosis. You see the ultrasound reports and all the things, almost 10, 20, 30% ultrasound report, you will find that fatty liver. But no one is more commenting or more focusing on this region, that is pancreas fat. And in next 10 to 15 minutes, I would evaluate, or I will try to cover how the pancreatic fat evaluated by radiologist perspective, how it helps or to make a decision making in diabetic evaluation or in the drug making. So what is pancreatic fat deposition? We will see various imaging techniques and importance of the radiological imaging in evaluation of the pancreatic fat in next 10 to 20 minutes. So what is pancreatic fat deposition? We all know that overweight, obesity is a global health program that increase fat. Whenever there is an increased fat, it leads to deposition of fat in multiple organs, liver, pancreas, skeletal muscle, and it is known as steatosis. We know that non-alcoholic fatty liver disease, we are used to it. I think all clinicians or physicians are very used to this terminology, NAFLD. And there is a similar terminology that is called non-alcoholic fatty pancreatic deposits. And this is reversible pancreatic fat accumulation, which is associated with obesity without significant alcohol intake. So there are different terminology like pancreatic lipomatosis, pancreatic lipodystrophy, fatty pancreatic infiltration, NASP, all have different pathology. So this is pathophysiology. Obesity and metabolic syndrome leads to accumulation of adipocyte, or alcohol abuse or viral infection leads to acinar cell. Both the pathway leads to fatty infiltration of the pancreas, and on the radiologically we last see the end result, whether it is death of whether it is accumulation of adipocyte or death of the acinar cells and lead to accumulation of that fat deposition. In radiologically we see the end result, that is fatty pancreas. So fatty pancreas is associated with age, gender and BMI, and also associated with the diabetes, cardiovascular disease and sometimes pancreatic cancer. So now I have come across this article, how does pancreatic fat deposition leads to diabetes, or it leads to diabetes management. So this is the article that is published, and there is visual assessment of pancreatic fat deposition, and it is a grading system, how the grading system had to in relation to diabetes on BMI. So when there is an ectopic or excessive pancreatic fat accumulation in grade 2 deposition, it leads to 50% of the patient associated with the diabetes. Similarly, in the pancreatic tail, grade 1 or grade 2 deposition, it is associated with the diabetes. Why grade 3 is not associated? Because we come across grade 3 is a radiological criteria. It is hyperechogenic. It can be lead to cirrhosis or fibrosis. So most of the deposition in grade 2 or grade 3, fat deposition is associated, 50% cases are associated with the diabetes. So similarly, reciprocally, if we diagnose early or we detect early fat deposition in pancreatic head or in pancreatic tail, at least we can help them, or we can incidentally, we can send patient to for evaluation of the diabetes. So, and similarly, some pharmacological drug also has effect on the pancreatic fat deposition. I will not go with this because I don't think after passing of entrance exam, I have no relation with pharmacology. So, pancreatic anatomy, it is 15 centimeter associated with the head, neck, and ciliate process. It is gradually horseshoe shape, and this is the size criteria. I will not go into detail. But how ultrasound? Ultrasound primarily used as a screening tool and follow-up. It is widely available, easily accessible, can be repeated as often necessary, and no ionizing radiation. How does pancreas look on ultrasound? Whenever you choose the ultrasound plate, there is a head, body and tail just deeper to the left hepatic lobe. Why we am seeing this left hepatic lobe? Because echogenicity usually on ultrasound or CT scan, echogenicity or appearance is compared with liver or kidney. In every radiology, you have seen the isoechoic, hypoechoic, hyperechoic. What is iso, hypo, hyper? It is just a comparison. It is compared to this iso, it is compared to hyper, or it is compared to hypo. So pancreas looks hyperechoic and just deeper or just underneath the left hepatic lobe, just overlying the vertebral body, and it's also seen the splenic artery and splenic vein. So fatty infiltration, how it look? So just I told that it is compared with echogenicity is compared with liver or with kidney. Its look either iso or slightly hyperechoic compared to the liver. And depending on how we have developed or ultrasound grading system developed. So now I just want to emphasize that whenever there is a fatty pancreas, there is always associated with the fatty liver disease also. So for evaluation of the grading system, we cannot evaluate or compare the pancreatic fat deposition compared to the liver. So the grading system is based to compare the echogenicity of pancreas with echogenicity of the kidney. So grade 1 is pancreas and kidney looks similar, or echogenicity are similar. Grade 1 is pancreas slightly brighter than the kidney. Grade 2 is pancreas brighter than the kidney but still less brighter than the retroperitoneal fat. And grade 3 is pancreas bright or brighter than the retroperitoneal fat. So this is how the echogenicity change, the grade G1, grade 2, grade 3 and grade 4. You can see the bright pancreas in grade 3 echogenicity. But whenever you do the ultrasound or you ask for the ultrasound and your radiologist do the report, there is some points to remember. When there is a obesity, obviously the patient with most obese patient, it is difficult to evaluate pancreas on ultrasound and also affect the fatty infiltration detection. And pancreatic echogenicity also associated with the pancreatic fibrosis. So now the next step is quantification. When we on USG, we indicate that is a fatty infiltration, but quantitative assessment can be done only with the CT scan or with MRI. CT, we don't know the gold standard. Usually CT scan, whenever you evaluate pancreas, there is a fixed pancreatic protocol which detects complication. Also CT detect other pancreatic condition. So on CT scan, pancreas, this is a retroperitoneal structure which see the body and tail adjacent to spleen and kidney. So what is CT scan? Basically CT scan is a play of density. So fat, whenever there is a fat, it shows low attenuation. So whenever the triglyceride accumulation in the fat leads to a decreased density of the fatty tissue and fat appears darker. Sometimes there is a focal or diffuse fatty infiltration or there is a lobularity increase. Here you can see this is the extremely fat deposition or this is a grade 3 fatty pancreas. So now as we see that we can do the quantification with the CT scan by conventional CT or dual energy CT scan. What is conventional CT scan or ROI? ROI is a region of interest. We put the marker on the CT scan and we measure the HU of the pancreas. when in sequential follow-up after treatment or after thing, we can have a chart of sequential follow-up of the pancreatic density, and we can put on this. Sometime when there is a fatty liver or other pancreatic association, we can compare the density of the pancreas with density of the spleen. Similarly, though placing ROI in the pancreatic parenchyma gives you ounce per unit, that is HU, and triglyceride reduce the absorption of X-ray. So this is the basic CT scan physics. Whenever there is a X-ray rays, whichever structure reduce or less absorb, it looks less brighter. So this gives HU ranging from -20 to 150. So proposed diagnostic threshold for pancreatic steatosis is -36. So limitation is can not differentiate fat stored in adipocyte or extracellular space. In obese or in very atrophic pancreas, it is difficult, or boundary of pancreas sometimes blur and difficult to measure ROI. So this is PS index, that is pancreatic and splenic index, mean value of pancreatic HU on pancreas as well as spleen, and this you can do subtraction, and this indicate fatty pancreas. The threshold is -5. So now role of MRI. In radiology, whenever we are confused or wherever we see that we have only one option, that is go for MRI, go for MRI. So MRI has very valuable tool in assessment of pancreatic fat, or more assessment, more precise assessment, particularly pancreatic fat in quantitative terms. So this is the techniques: in phase or out phase MR imaging, fat suppressed T2 sequences, then proton density fat fraction, ideal or IQ sequences that is developed, and Dixon techniques. These are the all MRI techniques or MRI sequences that particularly evaluate the pancreatic fat, and we can quantify these. So in phase and out phase images. What is in phase output imaging? I am not going deeper into this, but this, how MRI works, it gives electromagnetic pulse to the body. Depending on the electromagnetic pulse, the water or the fat that gets excited or that gives reversible or reciprocal signal. MR machine suppress particular signal, and that gives particular images. So in different ecophase between water and fat molecule, that signal drop in out of phase imaging compared to the in phase imaging suggests presence of fat. More it is used in the pancreatic adrenal adenoma. Here you can see the bright adrenal, and it is out phase imaging, it is darker. So this is the typical of fat deposition, and same parameter we can use in the pancreatic fat. T2FS images, it is a fat suppressed images. So whenever there is a pancreas, there is particular focal fatty lesion or focal fatty infiltration, we can evaluate with the T2FS images. Some proton density fat fraction, that is PDFF images. I'm not going into detail, but it is a specialized MRI technique that we can do quantification. This is the sequence, and in this, on head, body and tail, we can put ROI, and software can calculate the amount of fat or amount of the fat infiltration within the pancreas. Similarly, ideal and Dixon sequences. So, still confusion what to do, there is so many sequence, so many things. So, how does radiologist can contribute in this? So, in obese patient with high risk of metabolic disorder, you ask for evaluation of pancreatic fat, quantify if possible with USG grading and follow-up, and try your radiologist or ask your radiologist. Whenever possible, you can give the, just like fatty liver, give the fatty pancreatic grading. As and when required, ask for CT or MRI for quantification on help in treatment prognosis, because some promising new drug have effect in the pancreatic evolution. Thank you very much.